Sorry, class. Okay, now we go straight to the cases that we excited to work on. Do you want to start with the case that doing doctor and patients? So the aside group can be can go play the role like patient and doctor for the first case. Hi, Dr. Fu.
Yeah, so we will present case 1 of team A. Is that okay?
Yes.
Hello, everyone.
Hello.
Yes. So my case is a 56-year-old Hispanic female presented to the hospital because she had a declined visual acuity and her she feels numbness in her feet.
Okay.
Yeah, her post-medical history is with hypertension, and she didn't see doctors for nearly 10 years. So our differential diagnosis here are microvascular complications of hypertension, and the other one is microvascular complications of diabetes. However, she had never been diagnosed with diabetes. So therefore, the plan for us, the first step is to take the, okay, so we skip the history taking part. I will move, the first thing I want to do is taking some physical examination. The first is taking her vital size and focus on her blood pressure. Secondly, I want to make a meeting with an ophthalmologist and a podiatrist. We can, for the vision change, we will have some eye examination. We will, by an ophthalmologist, and maybe like side testing and retinal photography. And for the feet numbness, we have the feet examination. For the lower extreme vascular examination and the small fiber to test the small fiber function, we use a pinprick or temperature sensation about the large fiber function. We use 10G filaments or the vibration perception of the patient. And the protective sensation, we also use the 10G filaments to test. The lab test requirements, we decide, firstly, we would do the random leukoplasma, the random plasma leuco. If it's high, we will move to the next step, maybe the hemoglobin A1C or the fast leuco or the 2-hour plasma leuco to detect whether the patient has diabetes or not. The other test we will take is the urine, the creatinine, the AST, ALT to check for the liver function, the kidney function, whether if we use medications after that to decide what medication we would choose. And the imaging, we use Doppler ultrasound in the lower extremities. And finally, our diagnosis is microvascular complications of type 2 diabetes. The medication we give to the patient will follow the ADA 2018 guideline of, and in this patient, we will give anti-hypoglycemic therapy like insulin or oral medication. It's based on the level of hemoglobin A1C and to the specific of this patient. And another thing is we will treat the hypertension by anti-hypertensive therapy. In this case, our team wants to choose ACI and or ARB. For the patient home monitor, we will advise the patient to monitor her blood pressure at home using electronic manometers, and also monitor her blood pressure at home using a blood glucometer. And I want to tell the patient to notice the symptoms like polydipsia, polyphagia, polyuria, or if she increased numbness on her feet, or her visual is decreased quickly, or she feel some symptom of hypoglycemic like fatigue, sweat, fast heartbeat, heart rate, heartbeat, or something like that. She needs to go back to the hospital immediately to check. For the home blood glucose management, we will advise her to take medication every day as prescribed, and she needs to test blood glucose every day before or after the meal, and before going to bed. She also, if she is obese or overweight, she needs to reduce her weight by a diet or exercise. Diet, I think we will follow DASH, and decrease the glucose intake, and instead of that, we advise her to eat food with full source of proteins like chicken breast and other vegetable. And in case she's taking metformin for her treatment, there are risks to have B12 vitamins deficiency. So we will ask her to supply this. And about the physical activity, we will we will advise her to take walk every for about 150 hours per week of walking. Okay, 150 minutes per week, and every day it's like 30 minutes per day. Without it should be continuous, and it should be like shouldn't be like okay. Okay, so and to the complication prevention, I think that she needs to keep her blood pressure and keep her glucose blood level in the goal, and she should take medication, strictly follow the guide of the doctor, and she needs to keep a balanced diet for her condition, and also in the diabetes patient, she needs to protect her feet by wearing shoes that have the function to protect her feet. I know that there are some shoes that have that was advised for the diabetic patient. Yeah, and assiduously check the fasting cholesterol profile for at least once a year, and check and visit the ophthalmologist at least once a year for checking the vision change. Visit doctor at least once a year for blood tests like bone or creatinine. Check for the protein in urine and measure the kidney function. Yeah, and yeah, and she need to call to see the doctor if she have a if she or her family noticed that she had some other complication of diabetes, especially for the DKA or HSNS.
Okay.
Yeah.
Is any other member in your team want to contribute more in the case? Any other ideas from the case that you guys want to talk about? Yeah, you can sit there. Hello.
Hello.
Yeah.
I will say more about the diet
Okay.
for the patient, and diet should be supply more nutrient-dense foods like whole grain, vegetable, fruit, and legumes, lean meat and nuts, and restrict the high fat or high carbohydrates of food. Yeah.
Okay. And in terms of teaching the patient or the family at home, what else you want to teach her besides those teaching that your friend gave it to the patient?
The patient should check the patient should check her glucose every day before and after meal, and maybe at the bedtime. Yeah. And she should record write note on the measurement and the next time she come to the doctor, she should say about his glucose, her glucose for him.
Okay. All right. Anything else? I'll give you a feedback after. Anything else on your team want to contribute to the case? Are you done with the case? We can. I can give you the feedback.
Yeah, some more feedback to our presentation about how to diagnose the patient. I think we should do the EMG to know if there is any damage to the sensory nerve of the legs.
Mm-hmm.
Yes, and about medication or treatment, when we prescribe the patient with metformin, like monotherapy, we should guide the patient to revisit to if we need to change or add another drug, or we have to combine with insulin. So we should follow the patient every three months to check the blood glucose or hemoglobin A1C to titrate the medication for the patient.
Yep.
Okay.
All right. Thank you. So, so I have a feedback on this case. First of all, the presentation of the case is very good, very in detail, for the diagnosis, you should explain to the patient more about how you approach to the diagnosis. For example, you're going to tell the patient, okay, I'm going to test your blood glucose. I'm going to test your hemoglobin A1C. If it's high, so you are now diagnosed with diabetic. And we're going to develop the plan to treat you. For that, you're going to prescribe the patient medication. Normally, the treatment guideline recommendation is we start with metformin first. However, in the newest guideline that not really become a guideline yet, but the newest recommendation is now they tend to tailor the patient individually treatment with the development of the new medication, GLP-1, DPP-4, okay, new oral anti-diabetic medication. Now is metformin probably going to be go to the history soon. Anyway, so we still go with the current guideline that metformin gonna be first, and you're gonna in terms of prevention at home, you're doing good. That advise patient with diet. Normally, we advise patient here in North America. We advise patient follow with 1,800 calorie diets. That means patient have to learn how to count calories. They need to see the nutritionist or dietitian to see what kind of food that they should get, what kind of food that they should not take. The general idea at Yuri said, like low fat, low carbohydrate, and let's say the 1,800 calorie diet is the recommendation for the diabetic patient. And another thing about teaching is, I forgot your name, but you said check glucose before and after meals. I don't think after meals is recommended. Checking glucose before meal is recommended, but after you eat, it's going to be like 200. What's the point of checking it? So checking glucose before meals and before bedtime is good. And keep the log and show your doctor for the following visit. And for hypoglycemic teaching, when you said when the patient have developed sign and symptom of hypoglycemic, like feeling sweat, feeling fainted, feel lightheaded, dizziness, shaking, patient should go to hospital to check. When patient have experienced hypoglycemia, she or he have no time to go anywhere. They need to act right away or they're gonna be fall on the floor. So you should tell the patient carry candy bars, have a carry juice in their refrigerator. If they're at home, they should get some snack to eat when they feel those symptoms. Don't go anywhere, especially driving a car or driving a motorcycle to the hospital is dangerous. It's a wrong advice. You do good on this. And you said you're gonna you should teach patient about the complication. On this patient, she already have let me see what case. I think this patient, she already have complication of peripheral neuropathy and retinopathy. So it's already affect her eyes and her peripheral nerves. So we need to really tell the patient that she need to get her blood glucose control better to slow down the process of retinopathy and neuropathy. What happened already happened. We cannot reverse the damage that have been done, but we can slow down the process by control better the diabetics. By doing that, you should do fundoscopy, look at the patient eyes whenever they come to visit you, and recommend patient follow with ophthalmologists yearly, as well as the podiatrists yearly. We don't have podiatrists in Vietnam, but in North America we do. So if we don't have the podiatrist, you as a primary care doctor can do the food check for the patient, diabetic food check. I do it all the time. So you do well by doing the filament checking to check the sensation. The other thing you can do is use the tuning fox, which is called Thoa in Vietnam, to check the vibration sensation as well. It's very important. That one of the sign that patient lose first, the vibration sensation, and check the deep tendon reflex as well. So on this case, I think you do good on that. What else? And you need to counsel patient about the protect their feet by wearing shoes. If some small wound come out, then it need to be taken care before it's get infected, and get worse. It's hard to heal, things like that. Yeah, patient will be at risk of losing their foot, their limbs, or blind, or renal failure. They ended up in dialysis. And for the complication of the other thing, the acute complication is HHS and DKA. You can explain it to the patient more. I think that my feedback for the case. How about your opinion, Dr. Din?
Okay. I would like to ask two people in the team A. Okay. First one, Khôi Nguyên. Hello, Khoi Nguyên. Okay, I turn it on. Yes. Okay. Now, because we don't have food doctor in Vietnam, so as a medical doctor, you have to check the patient's food. When you use the monofilament, which area that you test on the patient's food? Number one, and no, second, numbers two, which area that you look at the food of?
I think we use monofilament to check the sensory of patient in his food, his bottom of food, right? I find that we have testing 9 or 10 points in every food.
Okay. And which area that the diabetic people have as most frequent open wound?
The first, the third, and the fifth fingers.
Okay. Good, very good. You passed the test. Okay. I'm very happy that you can answer all. Okay. Now the second, you can back to your seat. Now, Chí Thiện. Hello, Chí Thiện.
Hello, Dr. Dean.
Hi, Chí Thiện. Now, in Vietnam, you know that a lot of people use herbs, thuốc nam, to treat the diabetes. Do you know anything that you can tell us?
And when people use with their diabetic status, it can lead the patient to the complications that because in the herb there is something just look like metformin, and it can make direction to the hypoglycemia, yeah, and something like acidosis.
Okay, now I just asked you, what did you tell the patient or ask the patient if you want to explore the patient using the herbs or something that's like traditional medicine? How do you deal with the patient with that? Suppose you in front of patient. So which questions that you ask them that you can explore that they use the herbs or not?
Actually, the patient rarely to answer the question when we ask them directly. So so we will ask them question such as I just ask directly. I don't know anything any more question to ask.
That's okay. Thank you. Okay, class. Okay, your role that you have to learn about all the medication like herbs medication that the people use. I don't know, because here in North America we have the different okay, but in Vietnam you should know that, and you ask them, are you using something that, okay? So that's a take home message. Okay, thank you, Chí Thiện. Okay, now I think that we move to the next case, Brian. I think so.
Yeah, I think we should move it to the next group, and then we come back to the first group for the second case that they are outside.
Mm-hmm.
Yeah. Let's invite the next group. We can have a whole group come up here so we can like open discussion and talking as a group panel.
So you like to ask the team B?
Team B, please.
Okay. Now team B.
Please, team B, can we all come up here? That would be great.
Mm-hmm.
Hello.
Hi.
Hi.
Yes. My name is Naman from Team B, and this is D.
Yes.
Yes. My case is the case number 3.
Okay.
Okay, and I will go straight to my diagnosis.
Okay.
Okay. The first thing I think is the hyperglycemic state, because this is the complications of the people who have the diabetes, and the sign and symptom may include the dehydration, or maybe the weakness, and sometimes they can have the many level of consciousness, and it can occur without prior history of diabetes type 1, and many other trigger can be the infection, or from a stroke, a trauma, or a certain medication, and sometimes it can happen after heart attack. And my different.
Hello, Brian. Just turn on your mic.
Oh, I'm sorry. You talk to me like talking to your patient. Explain to me like why you diagnosed me with that diagnosis, and explain to me like your patient. Tell me. Keep going. Yeah, I heard what you were talking about, but yeah, keep going.
And because they also have the nausea, vomiting, and abdominal pain, so I think the patient is having the HHS syndrome, and then the different diagnosis is I think is also DKA. That's mean diabetic ketoacidosis, because it have the same sign and symptom, and it often happen with the patient with diabetes type 1, but sometimes it can also with the patient in type 2. So we have to check some lab tests. The first I want to check is about a fasting glucose, and then the results is very high. It's 925 milligram per deciliter. So the next thing is about the serum osmolality. It is 341. It's also very high, and serum ketone is negative. And some lab tests I want to give the patients is also the urine creatinine and urea creatinine, and some electrocardiogram, because the patient is very 78 years old, and also the urinalysis, and sometimes
they have to check again for the hemoglobin A1C. And about the medications and the treatment, I suggest the patient first is about the IV fluid.
Sorry, Naman. Okay.
Yes.
As Dr. Brian told you, now, don't make the report to the doctor. You just talk like you talk to the patient. Okay. We don't test your knowledge. You all know the knowledge. You know the test. You know, but how you explain to the patient with a plain English? Okay, say that I said okay, I will check ACG. That's you report to us. Okay, but with the patient, we say that, oh, now we will do something that to see that your heart is wrong or something. Okay, so you have to translate your medical term to the very plain English for the patient. That's the purpose of our class today. Okay, we don't talk about knowledge. We talk about how to communicate with the patient. Okay, I'm so sorry that we waste a little bit of time now, but go back again at the beginning. How? Okay, you don't need to talk very in detail medical terms to them. Just suppose that you in front of the patient and you talk to them. Okay, and all the class at the rest, everybody do that. Okay, okay, we don't test your knowledge. Yeah. Okay, thanks.
Okay. So I will start again. Hello, and my name is Naman. Yes. Your grandparents is having a serious problem now, and I think he is having the hyperosmolar hyperglycemic state. This is a complication of diabetes type 2 that he is having, because he is in a coma state, and I have to check, and also at home he's vomiting, is noises, and have abdominal pain. And the different diagnosis, I think, is DKA. That means diabetic ketoacidosis. And because the two diseases have the same symptom and the same thing similarly, so I have to do some other lab tests to clarify which thing that he's having. And first, I want to check the fasting glucose, and the reason is very high, 900, and also the serum osmolality is very high, and no serum ketone. So my suggested treatment will be giving him intravenous fluid to make him not dehydrated, and then I think is about some antibiotic to prevent infection that he can have. And also the other lab test is ECGs to check for the heart, and some electrolytes, or maybe some urine analysis to check for her urine. And then I have to monitor him, especially the blood glucose hourly, because his blood glucose is very high. And then when he's at home, he have to have the management very strictly, to avoid other kinds of complication. First, he have to check for the glucose, blood glucose at home, and take medication regularly, and take medication before the meal and check for after before the bedtime, and then do not skip any meal because this is also dangerous too. And he has to protect his skin and his food, and by wearing a sock or wearing shoes every time at home or when he's walking out. And if he has any wound, he has to be careful and treat the wound until it heals. And have to check for his eyes every year, and also check for the hemoglobin A1Cs every three months. And for the complication preventing, he has to keep the blood sugar under control, and then if he can, he has to do some physical exercise regularly, maybe 2 or 3 hours a week, and especially the diet. He has to take a healthy diet with a low glucose intake, and a lot of fiber in fruit and maybe vegetable. And then you have to do some screening and do some test review for preventing the complication. And especially he has to cut down and avoid smoking, avoid alcohol, because it can increase the complication. And that is one thing I want to tell you about your grandparent.
Okay, class, stop here. Okay, we don't have more time. Now, I would like to ask all of you in the class, is this a good plan to talk to the patient case or no? Like Naman already talked to the patient or everything about his plan to the patient. But how do you think about it? Do you try to explain the patient or educate the patient with the patient like looks like an emergency like that? You have time to do that? Or you have to do something? I give feedback to Dr. Brian. Okay.
Okay. Yeah, for the second round, you do it very good. You do it. You communicate with the family member of the patient is the way you're supposed to be. So there's a you did well on the teaching of the skin protection, food protecting, teaching, follow up with doctor for A1C. However, you didn't make a very clear and precise diagnose. What are you treating the patient? Like you think you said patient have hyperosmolar, hyperglycemic state, and then you said, oh, okay, the differential diagnosis would be DKA, and you throw a bunch of lab, but you should tell the family or the patient, at this point we think patient have hyperosmolar, hyperglycemic state. So we're gonna treat it with IV fluid, with insulin drips, with electrolyte replacement. So the patient, it's gonna give a sense of secure for the patient and family. Okay, now the doctor is treating this condition. Don't act like, oh, we don't know yet. You know, we treated. Patient gonna be very very anxious as well, because they know, oh my God, the doctor didn't know what's going on either. So if you're not sure about diagnosis, you say at this point we think that what happened. We're gonna run more tests to make sure that there is no other complication or no other comorbidity going on to treat the patient. And like Dr. Dean pointed out, you need to use a more bland language for the patient. For example, like EKG, you need to explain like to check out the electricity activity of the heart at this point, because patient may have electrolyte imbalance, may affect the heart. Another thing you said about low glucose intake, we don't use the term of low glucose, we use term low carbohydrate. Carbohydrate is, as you know, including like rice, bread, sweet stuff, sugar, everything. When you can briefly educate family member about how to avoid further complication, like how to avoid for this thing that happen again. For example, like don't let patient skip the meal, skip the medication, don't let the patient dehydrated. But yeah, in the ICU setting, you probably don't have time to teach, or like for food teaching, like long-term complication teaching, like that. Dr. Long, do you have any advice for the team?
Okay, this is case when the Nam An presentation, I think about this emergency. The patient come in with us in emergency room, not in the regular room. I feel look like he talk with us, look like normal case. In my mind, this we need to do this for the patient education later. The first, we're looking for diagnosis right away. The patient have decay or no, because decay very important, very low pH. If you not control pH right away, medication come in the body not working. That means you need the control pH by look like you need the less gas. Look like I give for you ABG, this artery blood gas. You need looking for pH, look like bicarb. After that, you can use bicarb drip, or other one I heard about, you give the patient 900 milligram glucose in the milliliter or something. But you need the insulin drip, or you need the treatment right away, because this is an emergency situation. Another one, you get a lot, explain look like differential diagnosis. I think we need focus in the patient size and syndrome, and some test for emergency. After that, we differential later. This I have idea. But other one, I think Ryan, he know more than me, because the whole point for the diabetes patient. But I just tell you about how we do in emergency room. Okay.
That's good. Okay, Naman, you say, okay, you have to present this case, emergency case, not normal case. So
yes,
the wording you talk to the patient is quite different from the patient that's in, you know, stable condition. So that's the point I would like to tell you, because the patient show up in the hospital with nausea, vomiting, and everything, and you didn't say anything about it. You have no plan about that. That's correct. And you just go like you go by the textbook, but you don't go to the real case. You have to have the sense of urgent here. Okay. So the wording, the way you talk is different. Thanks.
The three things in the case, we need treatment right away, the hydration, other one, the insulin drip, and other one, the acidosis. That's the 3-4 we treatment in this patient. In my opinion, Ryan can give more idea. Thank you so much.
Yeah, I totally agree with Dr. Dean and Dr. Long, because DKA and HHS are the two complications that is emergency, including hypoglycemia. One time I have to pull out the intern resident to the side, give him a big talk about the patient management, because he let the patient stay in the ICU 4 hours without starting the insulin drip and IV fluid. I said, do you want to kill the patient? Next time I'm going to write you up. So we have a good sense of emergency case. So this is a very good lesson. Okay. So do you have any question for us?
Thank you. I just realized how to respond to an emergency case, and I will pay attention for the next time. Yes. Okay.
Okay. Other than that, you're doing very well. Okay.
Naman, you did well. Okay. Yes. You would completely everything there. Okay. But this one is a process of learning. Yeah. Don't feel like, you know, don't feel bad about that. Okay. But you should think a little bit out of the box rather than just go step by step. Okay. It's not reality. Okay. I think, Brian, maybe we move to the team C now with the okay, because we don't have much time.
Thank you, guys.
And then after that, we make the whole assessment for everybody. Okay. Thanks.
Okay. Hello.
About my case, a 48-year-old male with that medical history of diabetes type 2 come for non-healthy one on his left foot when he stepped on a rotted nail in his backyard 2 weeks ago. He went to an urgent care clinic and was prescribed an oral antibiotic, but the one did not improve. He reports he stopped taking his metformin and libraries 3 years ago and started to take some herbal medication that his relatives showed him. His left foot now is swollen and erythematous up to above his ankle.
Okay. Yeah, I'm your patient. Talk to me.
Yeah, that's it. After
what's going on with me, doctor? What do you think going on with me, doctor? What do you think what are going on with my foot?
Okay. Speak louder. Speak louder.
And after I take your physical examination and diagnosis is for your information is your problem is diabetes food infection.
Okay.
And another different diagnosis is blood vessel congestion.
I'm sorry, what's that?
Blood vessel congestion.
Blood vessel congestion?
Yes.
Okay. Yeah, keep going. I'm listening.
Okay, and I
how do I
often
treat it and stuff like that? Do I need to take tests? How do you treat it? Would you tell me more?
I will take you to some tests, and I also do the follow-in with blood test and CRP to check that have any infection on your foot, and the second, because you have much medical history in diabetes, so I will give you check random blood glucose and combined with hemoglobin A1C to check the level of blood glucose, which means blood sugar. And I have some test, imaging test to measure my diagnosis is a vascular ultrasound to detect blood clot. And I have some tests to find early complication for liver and kidney tests like urinalysis. And about your treatment and medication, I will set immediately intravenous antibiotic and insulin. And I admit you go to in hospital, and I will monitor you every day by a full one examination about character, location, and size. And I will take your vital sign every day, and about your concern, and about blood glucose by your glucometer drip at 5 o'clock in the morning every day. And I will call for nutritionist to write meal plan for you. Next about the home blood sugar manager in your home, I will give you 5 advice. The first is set blood sugar regularly by a glucometer. The second, you should keep a balanced diet. Don't keep your meal. You should eating the healthy foods like fruit, vegetable, or whole grain. And the third, about your exercise, just simple, don't heavy or excessive. And you must remember that don't do it after you taking insulin, because it makes you have a low blood sugar and you have trouble with it, your brain itself. And the fourth, weight control. And the last is, if you are a smoker, you should quit smoking. And about the complication prevention, the most risk factor with your case, I think that's about amputation. If you can treat it by any antibiotics, so maybe the final way I will do with you amputation. But I think if you want to avoid the amputation, you must you should follow up with me and take medication daily, and you must treat your fish daily, fighting kinship or ulcer. Keep your feet clean and moist, and don't go barefoot. You should wear so outside or other inside your house. That's all.
Okay. How about your team member? Do they have any contribution on the case? Do they have anything to want to teach me as a doctor? Hi, doctor.
Hi. I will suggest you with a meal plan for you, a diet. We recommend you to remember the size of your hand. You have to eat rice in like this, in the size of my fist, and eat beef or protein in the size of your palm, and whole grain in the size of your hand like this, to reduce the risk of high blood glucose. And about your food, because you are having a diabetes condition, so you are at the high risk of infection of your food. It may be become to the amputation of your foot. So you need to follow our advice very carefully and strictly to reduce the risk of infection. And remember to take your medications every day and check your blood sugar every day. And you need to check your hemoglobin A1C every 3 months to find so that we can find the early communication, or we train the treatment plan for you. And you should visit doctor at least once a year for some tests such as blood test and kidney test and liver test to find any complications.
Okay.
Okay.
Yeah. Okay. The teachers, would you give would you give the team feedbacks, please? Hi, Dr. Hall, Dr. Dean.
Hi. Okay. I think that the plan, you have to stick with the main situation of the patient. You can go around with the education, everything. That's fine. That's good. But this one, the patient is a diabetic. Number two, he has a trauma. Number three, he has the leg swollen and red something. So you see, there's a three main thing that you have to concentrate on. Okay. So that's good. You think about infection, something like that. Okay. You start to plan the antibiotics. That Dr. Luang said that why you jump to right to that. You have to figure out what you have to do with that one. About the diet, that's good, but really there's a little bit like urgent, a little bit emergency. You have to treat something around that. Okay. I think that I give the feedback to the other one, but I would like to tell all the class that you shouldn't use the phrase like my diagnosis is blah blah to the patient, because it's a very medical term. You just say that I think this is maybe something. So it's easy for the patient to understand. And about the other diagnosis, you say how you say that blood pressure congestion. I really don't know what is the diagnosis about that. Okay, you should, if you use medical terms, you have to use the correct one. You don't invent. Okay, you can explain to the patient, but you don't invent the medical term like that. So maybe you have to explain something else. Okay, okay. And ultrasound, you know what kind of ultrasound is used here? Usually in this case, we use a Doppler. Okay, but why you use it and which purpose that you use it with the patient diabetic and with a swollen foot. Okay, that's it. I give the feedback to Brian and Dr. Welcome, Dr. Anfu. Welcome, Anfu. Okay, if you feel you have something to tell the students, we very appreciate that.
Hello, class. Can you hear me?
Yes.
Okay. Sorry, I'm get crashed. Today is not my day, but I just haven't got nothing else to do at home. We're supposed to do bike riding in the beach, but my daughter is quite sick, so we canceled the trip. So I just a bit of get crashed. I think I'm just mainly I like to observe case today, but I got a few things. The students still lack a systematic approach. All the chronic case or chronic patient, chronic disease patient, you have to make sure you put a plan in your head, like short term and long term. Usually it's more acute when patient get ulceration, most likely peripheral vascular disease because of diabetes, or could be something else. We can't just ignore, like I agree with Thảo, it could be something, peripheral vascular disease from the venous ulceration, or DVT, deep vein thrombosis, something there, could be something happened there, but I'll leave it. So make sure you always, in medicine, you can't remember everything unless you got a system in your head. But I mention all the time to tell the student that you don't develop this habit. You're always struggling to find a word and try to speak to the patient. I just say you go home tonight, you're looking at what my short-term management of this patient is, and my long-term management. It applies for every other case that people with, like neurology, any other thing, over the long-term management. Weight loss, I'm not agree with Thảo about insulin injection. You don't do exercise. It's something a bit too dramatic there. So, in terms of, I think probably maybe I'm not sure how Brian feel about the case. That I didn't see any much more history. You might get a bit more history from the patient, how well she managed blood sugar, how he do it. Basically, we need to get a patient get a record of the blood sugar. At least they write it down what they record every day to see what their blood sugar. Home glucose monitoring the revolutionized measurement of diabetes. So everyone should have the machine, diabetic patient machine. They should have the record, and you need to look at record. The patient can falsify the record, the number, but when you look at the machine, there's always memory in there. You can check it. So, but again, I want to talk too much. So make sure long-term, short-term first, and long-term. Long-term, I type in there. Especially diabetic, you have to look at the global management in general. Management, lifestyle, dietitian in Vietnam. Not sure you have the dietitian, but you talk about. Brian might agree with me. We always have the dietitian team there to consult, to help. We're not managing alone. We're managing multiple. They call diabetic or multidisciplinary. Management, multiple team involved, not just only one. So they got a lot of other chronic disease. Most people have a lot of disease, cholesterol, they have the hypertension, they have many other causes on that. They're quite high risk patient. So okay, so I'll leave it back. I'm sorry, talk too much. I'll leave it back to Brian. So
thank you, Dr. Phu. This is a very good advice. Yeah, so I totally agree with your advice that long-term and short-term management on this patient. However, for the team, this patient, you should look at the patient at the whole picture. What's going on with this patient? So to summarize on the case, patient has uncontrolled diabetic. He quit taking his metformin and glyburide 3 years ago and started taking some herbs, and that means that patient had no blood, no control, very poor control of his sugar. Okay, so and the incident happened that he stepped on the nails and got his foot infected and could the infection get worse. So that's why he present to your hospital. So you did very well to admit the patient, got IV antibiotic. However, you have to work up more on that case for the infection. First is to do more work up to see if that infection got into osteomyelitis, that infection get into like abscess, or got like cellulitis, or even necrosis fasciitis, which is another surgical emergency case, especially for a diabetic patient. The secondary is you control the diabetic for the patient. That being said, the short-term management of this acute issue right now is the issue I can address. For the long-term management, then you will teach patients how to manage their wound at home, how to prevent complication by diet, exercise. And then another thing you have to teach patient is compliant with their medication. That's another main point on this patient. Patient, a lot of patients in Vietnam, you probably know that they cold turkey quit taking their medication, and start some herbs out there, which is no statistical proof that it's going to help with diabetic. Okay, you do good in management acute, like blood glucose check, check A1C to see where he is, however, there's a lot of things that you need to do on this patient. You need to do blood culture, you need to do wound culture, you have to do the X-ray of the foot, the foot to see, or the MRI if you need to see any osteomyelitis, ultrasound of the foot with Doppler to see any DVT going on. You have to do like wound care for the patient as well while in the hospital, and teach patient how to wound care at home as well. For the long-term management, like I said, you need to really teach patient, and sometimes you have to involve the family member in terms to increase the compliance of the with the medication. You do good on telling patient checking A1C. You need to be more specific. You cannot say like, oh, check your A1C after 3 months. You said you tell or you say to another doctor. You tell patient you have to come back here to see us after 3 months. So we can check your hemoglobin A1C and blood glucose to see where you are. Then we will adjust your regimen of treatment. Don't tell patient you need to do this test in 3 months. You need to come back here in 3 months, or if patient have their own doctor, you need to see your doctor in 3 months to check for this. Okay. I think overall you're doing very good. Just like Dr. Dean said, there's no such diagnosis of blood pressure congestion. So don't create diagnose or don't create the terminology. It's just a no thing in a medical world. Okay. Yeah. Thank you, guys. Next group, please.
I think that we go back to, because every team already presented 3 cases. So now we have 3 cases left, and we have one for team A, one for team B, and one for team C. So it's up to Brian. You can call any team there and to present the last case of the team.
Yeah, okay, let's call team B, please, for the next case.
Go quick, guys. Okay. So slow.
Hi, doctor. My name is Ngon, and my case is 80-year-old male who lives by himself at home with a past medical history of early dementia, diabetes type 2 on metformin and insulin, brought in by his nephew due to lethargy, unable to wake up. His body was covered with feces and urine. Blood glucose reported 15 milligrams per deciliter. And based on this thing, I think you are hypoglycemia. That is a low blood glucose caused by insulin. And differential diagnosis is stroke and heart attack. Firstly, I will quickly check airway, breathing, and circulation. Then I will give you glucose IV 20%, 50 milliliter. Then glucose 10% infusion, 5 milliliter per kilogram into a large vein with large gauge needle.
and thiamine infusion. Then I will check vital sign and monitor blood pressure, respiratory rate, and pulse and glucose every 30 minutes, 1 hour, 2 hours, 4 hours, in 12 hours, because prolonged hypoglycemia may cause cerebral edema. After 50 minutes, if the patient improves, he is conscious, and I will ask him about his medical history and past medical history, to identify the cause of hypoglycemia, to give the proper treatment. If the patient still get worse, I will take the examination focus to distinguish between metabolic disease or structural one. Then I will give the patient laboratory tests like arterial blood gas, complete blood count, urea, creatinine, electrolytes, liver function test, and a CT scan. And then move to the patient education. I will advise the patient and give the patient information where the early signs of hypoglycemia, such as sweat, heart, increased heart rate, shakiness, and the way how to fix them. And important that have protein breakfast, use nutrition, yeast, berberine, high potassium food, and do not skip meal, and do not consume carbohydrate because you are diabetes, so your glucose will up and down. Then I will advise the patient follow direction on the prescription label. Eat meal 30 to 50 minutes after using Novolin. Advise the patient know your blood glucose goal and check it regularly. And prescribe a glucagon emergency injection kit to use in case of severe or the patient cannot eat. After assess the ability, cognitive ability, because the patient is demented. Based on metformin and Novolin, I think he is treatment in step 2. So consider change Novolin to GLP-1 or TZD. Yes, that's all.
Thank you. How about your team? Do they have any contribution? Yeah. How is your team members? Do they have any other contribution? Any other advice to my dad who's sitting here? Okay.
And then other team members. Okay, it's not you, Ngan, but the other one in your team. Do they have any contribution to your presentation? Yeah.
I think the patient has determined. Yeah,
Demented.
Demented. Sorry, the patient has demented. So we should educate about family and and the patient about using drugs in diabetes, and I should evaluate that demented. The patient can care young chef to need support a nurse or family don't stay young chef at home alone.
Okay.
And that's all.
Okay, thank you. The other instructor, do you have any advice, or do you want me to go first? Okay, I can go first on this case. I'm going to give you feedback on this case first. You need to visualize your patient, because he's lethargic, he demented, and you keep talking to him and ignore the family member in the room. This is not right, because he's not going to understand what you say, and then the family member is the one that's really talking to this case, because your patient lethargic. You have a very good differential diagnosis. But you really need to reword the way you talk to the patient. At this point, I think your dad probably have a hypoglycemia. However, we need to exclude the other causes, such as he may have a stroke, he may have electrolyte imbalance, or he may have an MI, a heart attack. So we need to run more tests and figure it out. In the meantime, we have to treat this hypoglycemia by giving 20% of 20% glucose, like the regimen that you said. That's very good. The other thing you should do is you should run an EKG stat. You should do after the blood glucose come up, you should have run a CT scan on his head. The other thing is you have to check his hemoglobin. You have to check his hemoglobin A1C. You have to check his blood glucose stat. Even though people report to you by ambulance his glucose level was 15, but you need to recheck it. At this point, it may go lower, or if he responds to the treatment that you gave. So sometimes you give 20% of glucose, 50 cc. The blood glucose had not picking up yet. He need more than that, probably sometimes. So you need to really monitor blood glucose closer. And you did check blood gas, electrolytes, stuff like that is good. On your teaching, you said you wanted you will work him up on metabolic disease and structural disease. I mean, it's the very vague thing to tell the patient. You need to be more specific. You can put like, when he getting better, we're gonna work him up more to see any other underlying causes for his hypoglycemic, like infection or other disease, but you don't put like metabolic disease, stuff like that. It will make patient, family more confused and they more worry. One of your advices, you say like tell patient do not consume hypoglucose food. I never heard something like hypoglucose food. I think it's a wrong advice. We always advise patient with diabetic patient to consume low carbohydrate diet. They call low carb diet always, even though he experienced hypoglycemia. But you got to understand hypoglycemia is normally causing by on diabetic patient is overdose of insulin themselves, or overdose of overdose or side effect of oral anti-diabetic medications, or they take medication and they don't eat the way they're supposed to be, or they miss their meals. Those are the cause. The food never cause hypoglycemic. Okay, the medication cause. So one of the one of the complication when we start patient on the regimen, especially especially when you put patient on insulin or urea agent. Metformin is less likely causing hypoglycemic, but the other agent can. Okay, just keep in mind on those. You can teach this consider an emergency case as well, but you can also touch base with the family members. They're kind of briefly teaching them, like make sure your dad take the right dose of medication. Make sure your dad don't skip the meals. Make sure your dad have someone to watch over his medication. And long term, you might want to have someone to live with your dad, or he need to end up in nursing home because this is I don't think that he can take care of himself safely at home. Like your friend that give a very good advice that he needs someone to live with, because it's very dangerous for him to live at home with the demented and insulin. If you you cannot do much about patient situation. Sometimes like patient refuse or family didn't want to go to nursing home or something like that. You need to really change the regimen of your patient. You don't put him on insulin anymore. You need to find another oral agent to give the patient less likely to call hypoglycemia. And another thing I forgot to mention is teaching the family like to avoid hypoglycemic. Like he need to keep his cup of juice in his refrigerator. Carry candy bar on with him when he go out, things like that. So that's my feedback. Dr. Dean or Dr. Ho, would you please give the advice?
I think that we move to the other case, okay, because we have two team, 2A, team A and team C, and each one has one case. So Dr. Fu, want to talk something? Yeah.
I think this case is very much acute management. You need to design your own plan very quickly in your head, how you manage it, thinking you are in emergency room. So A, B, C, D is a must. So what I would say, this patient, I didn't get a case, clear from beginning. I presume this gentleman, 80 years old, live alone, felt unconscious, he has a post-surgery dementia, early dementia, and also he felt possible hypoglycemia. But I would say this is a very acute case when the patient being found unconscious. Possible different diagnosis could be from stroke, ischemic heart disease, hypoglycemia, or electrolyte disbalances, or some other cases. First of all, what I would like to do have to stabilize the patient. That's the first line you have to mention. And I will follow ABCD. First, I get the air, make sure the airway and breathing, patient breathing and circulation, make sure patient blood pressure and pulse, and I check what the patient, what medication has been taking. So that you have to one just single line that you have to formulate in your brain with every patient when turn up to casualty, like have a car accident. First of all, I need to stabilize the patient. I need to follow ABCD. That's the way you got to do. Drug circulation, intravenous cannula, IVC, the cannula in to get the blood. Those things, as always, just not without thinking. That's how you manage patient. I think this more case, more acute patient. You shouldn't spend too much time with the long-term management. Yes, the patient quite ill, quite sick, and you keep talking to the patient. I think that probably not true. He wouldn't probably understand the damn thing. So you need to talk to have the taking place through someone has witnessed, someone that found him at home or any close relative. You need to take history from them. That's the more precisely and more accurate, history. You have no idea when a patient like this, you ask him, especially we have to ask a Glasgow Coma scale, or ask orientation, where you are, where you are, what the date, what the thing. They probably wouldn't remember anything, so no way you can take it from him. So very, 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 it's a very interesting case. I think Dr. Mindo, maybe great because he worked in geriatrics, saying they've seen a lot of patients, and you will see a lot of Vietnamese patients in Vietnam because people are living longer, home more often, and all the children working, in working. So we use the opportunity, go back to design your own systematic ABCD. I would do this emotionally and assign some tasks to the nurse to do this or that. Especially ECG, EKG, like American said, it's very important. Talking about OCT scan, probably laser, stabilize the patient. Okay. And so if you go to exam something, we see that you got something formulated in your brain, ABCD, that never go wrong. So again, systematic student, systematic, you're thinking that you never go wrong.
Thank you.
I want to ask a question. Kim Ngân use vitamin B1 to treat in this case. So I think it's not necessary because vitamin B1 only used when the patient has used alcohol so much in the past.
Yeah, that is true, but it's not necessarily wrong, because you can give patient vitamin B1. It's also called thiamine. You don't know much about the past medical history of this patient. He might drink alcohol at home. He comes with lethargic. You give glucose. Yes, it's mainly for alcoholism, but it's not wrong to give the patient IV thiamine at this point, because what happened if he's alcoholic and you give a lot of glucose, it's going to worsen the thiamine deficiency on the patient. And we normally don't check B1 level on the blood, so it's a vitamin, it's kind of prophylactic treatment. So that's why I didn't say she was wrong, but it's not necessarily on this case. Is that makes sense?
Sorry. Kim Ngân mentioned high potassium. I think probably you shouldn't use that think it's high potassium. Potassium kill people. So I have to be just stop using that word because it might make a patient drink potassium can cause cardiac arrest.
Yeah. Okay. Next team, please. Probably come back to team 1. Hello. What's your case?
Okay. My case in short is about 18 years old girl, type 1 diabetes, complaints of lethargy, nausea, vomiting, and abdominal pain. Her blood glucose is 500, annual gas 23, serum acetone high, and ketone in her urine above 100. About this case, first, I think this is an emergency situation. So before explaining her condition, I have to prescribe an insulin shot subcutaneously. It might be 20 units of insulin is enough. And after her status is improved, I have to talk about the information about her condition. The first, the differential diagnosis, I had 3 of them. First is ketone acidosis. Second is hyperosmolar hyperglycemia state, and the third is food poisoning or acute abdominal disease. Yes, my plan. I have to inquire her about abdominal pain and her diet 1 day ago to make sure that she did not has an acute surgical condition, and then I had to check her vital sign, her blood glucose, holistic blood count, electrolyte, urea, creatinine, ABG, and maybe abdominal ultrasound. Yes. About medication, in general, I will set a normal saline intravenous, insulin intravenous, and if any disorder in blood potassium or her pH is below 7.3, I have to order bicarbonate salt. When she is dripping, I have to monitor her mentality, vital sign, ABG, and blood glucose every hour. In short term, and in long term, I have to check her blood glucose and glycemic hemoglobin. Next to her management, I would tell her some information to make sure that he will manage her condition at home safely. Because you got diabetes type 1. You knew that, but I have to tell you once again
to make sure you know it clearly. In diabetes type 1, we just have one option to treat the condition. That's the insulin therapy. You have to take insulin before meal 15 minutes and before you go to bed. And so sometime in day, averagely 6 to 10 times a day, to make sure that your glucose levels is usually in control. About diet, very easy to know that you have to consume, you have to take healthy food and get away from bad food, reduce trans fat, red meat, and high glycemic index food. That's some food that make your blood glucose increase excessively and in the short time, like candy, cake, or sweet bread. So you have to prioritize to low GI food, vegetable, and nutrient-dense food. The best thing that you should visit dietitian for a suitable food cost and calculate your energy consumption a day. And you have to know that 1 unit of insulin should use for every 15 carbohydrates you take. You have to exercise at least 30 minutes per day with a moderate intensity aerobic exercise, and a week up to maybe 150 minutes. And if you have some prolonged sitting more than 30 minutes, you have to interrupt it by about walking or some light physical activity. And if she is diabetic, she is obesity, I have to recommend her to decrease her weight. She have to remember to keep her BMI range from 18.5 to 25, and if her weight is over than that, you will decrease your body weight not more than 2 pounds a day. Yes. And finally, about complication. Your complication may be hypoglycemia and hyperglycemia complication in your cardiovascular neural system, kidney, eyes, and a very common condition is diabetes foot. But because your age is really young, so this complication would not come so early, but you have to control your blood glucose to prevent it as soon as possible. And the overall methods are to keep your blood glucose level, cholesterol, and blood pressure within recommended range, and hemoglobin A1C under 5%. Remove blood glucose from 70 to 130. Post-meal blood glucose under 180. And blood pressure under 130 and over 80. Yes. Before And you have to remember that to take insulin shot on time and come to see your doctor in regulars or when you realize any abnormal symptoms.
Yeah. Before ending our case, I want to ask something about our case. The patient is firstly admitted to the hospital. Maybe she is unconscious. So I will ask for the history. I will ask for her her friends for the history because she has spent 3 days back in with her. Then when I have the diagnosis that in the first schedule acidosis, I will give the medication to the patient. Then when the patient is stable, I will give her the advice after that. Yeah, but I think in our cases, Kong is go into so detail. So I think the patient maybe can follow up. Yeah, we just say something more simple and make sure that and we try to find out the reason that the patient why the patient give up the medications because because the patient know that she has diabetes type 1 and must use insulin regularly, but in the history she skipped the medication and lead to this complication. So we need to do something like that. So we finish our cases here.
Okay. So let me go first on this case. You come up with the diagnosis is good. It's a typical case of type 1 diabetes and get into DKA. However, I didn't like the way the Coin approach to the case. First, your patient, as Dr. Ho pointed out, your patient is lethargic. She's not sea lion there. She may be unconscious. You cannot get much information from her. You cannot talk to her, and you have to talk to the family member or even a friend, a neighbor who brought her in at bedside. Try to get a little bit of information, history of illness from her. Secondly, before you go any treatment, you should inform patient at least your initial diagnosis or what you thought what's going on with the patient. You said, at this point, I think patient may have into DKA, diabetic ketoacidosis. So I'm going to treat her with insulin drip and IV fluid and try to balance her electrolyte. In the meantime, I'm going to run a series of tests, for example, EKG, the other lipase enzyme, run ABG, run the other lab work to check her electrolyte, to rule out the other cases. Occasionally, for young people who are partying like this, you may want to run the urine drug test to see if they take any illegal substances, or even you have to run the CT of the head to see if any head trauma that happened during partying. She may fall somewhere and she common with lethargic, and the blood glucose high, the DKA may be the consequences from the unconscious that she got before. For example, let's put the scenario like she fell and she unconscious. She didn't have a chance to take her insulin and she got into the AKA on top of the head trauma. So we need to rule out when patient come in with unconscious lethargic. You need to be very, very careful. You don't miss you don't miss the diagnosis. Okay. I don't know. You remember the case of Lê Công Tuấn Anh before he came to the hospital with lethargic, and people keep thinking, oh, he had head trauma, so they didn't check urine tox or like blood level of the other substances. I mean, he died from suicide. He took something that treat malaria, so he died from that. So back to our case. So my point is you need to rule out something else that can cause lethargic on this young lady who comes with DKA. Not just DKA. We don't want to miss the zebra DKA. We treat DKA. In the meantime, we need to digging more on the patient to see anything else that can cause this patient to come up with this one. So I really like coiling management with ABG, check the pH level, and work up for the patient. Beside those things that I would like to do more on that. There's something that you was mentioned about obesity. Most of the time, the patient with type 1, they don't have obesity. Type 1 is very young. You know, there's an exception, but it's not the case. The other thing you mentioned is complication on type 1 diabetic is not common early. It's not necessarily true. It's happened when in type 1 patient that you newly diagnosed, then it's not common early. They said about 5 years after the first diagnosis, then you looking for the complication, but you don't know this patient. This patient may have type 1 diabetic since she was like 12 years old, 10 years old. So it's been running for a while. She may ended up with complication right now. In the real world, I saw patients lose their vision in their early 30, or they ended up with end-stage renal disease dialysis in age of 23. I saw it also. So complication come about 5 years after the first diagnosis, of type 1. Okay. That's my comment. Would you please, Dr. Ho or Dr. Din?
I think that you talk all. Okay. Okay, Brian, maybe go ahead with the last case.
Okay.
Or Dr. Fu, you have something to say?
Yeah, do you have any question?
Hi, can you guys hear me?
Yes.
Okay. Hi, I'm the daughter. Yeah, so anyway, the only thing it was a really, really good case. My only problem is that, you didn't sort of look at like post discharge workup in as much detail as they probably would. In Australia, it's really, really important to look at like psychological issues for why the problem happened. So they're really into like looking into reasons that things happened and not sort of just going, oh, you need to watch your diet. Yeah, so just look at the reasons that someone might have had a DKA. Like they were on spring break. They were probably not like worried about their insulin or their sugar levels. They were probably too busy partying. Let's be real. So yeah, you got to take all that into account as well. And also look at their state. So yeah, you have to remember that they're lethargic and they probably won't answer questions. You have to get collateral history. All right.
Yeah, thank you so much.
Hello.
Hi, can you introduce yourself and your friend name?
Yes, my name is Phong, and my partner is Ben, and we will present the case number 6. The case, our case is 60 years old female with past medical history of type 2 diabetes. Comes with the complaint of not feeling well, nausea, but denies vomiting or diarrhea. She also has history of non-compliance with medication and diet. First, in this case, when the patient admit to the hospital with these symptoms, the first thing I want to check is the patient blood sugar level. So it can help me to know what the condition of the patient is. Maybe in this case, I think the patient has the two likely condition is the first thing is the acute hyperglycemia, and the second is hypoglycemia, because based on the history of the patient, she didn't compliant with medication and diet. So maybe this time she because of whatever cause, maybe her blood sugar level was increased, or maybe or in this time she was overdosed with the diabetic medication, so she had hypoglycemia. On physical examination, I think I saw the patient has severely visual impairment, peripheral neuropathy, and large. So these are the complications of my diabetes. So I have one more differential diagnosis in this patient, because she has complication with neuropathy complication. So maybe it affects the sympathetic nerves, and it make her stomach was distended. So this also sure. So I consider it. Oh, sorry. Okay. Go through the lab test. Go through the lab test, and so as I say, the first thing I need to see is the blood sugar level of the patient, and
So it helped me know if the patient has hyperglycemia or hypoglycemia. And the second thing is A1C level. So I can saw the patient, the blood sugar level of the patient at a few months ago. Next, I need CBC to find if the patient has the infection or something like that. Electrolytes analysis. I want to know if the patient has the problem with potassium. Also, I need to see the BUN and creatinine, so I can creatinine and AST, ALT. So I need to check the kidney and liver functions. So to consider the suitable medication and for this patient. And one more. In addition, I need cholesterol test and consists of LDL, HDL, and total cholesterol. So I also see if the I want to see the cholesterol level of the patient. So, and if it is abnormal, I will treat it. And ultrasound. Ultrasound I need Doppler ultrasound for the carotid vessel or peripheral vessel, and to see if any occlusion in these vessels. Also, maybe I need cardiac ultrasound to see the proper and EKG or even EKG to see the heart problem. The patient has the peripheral neuropathy, so so maybe I consider EMG for this patient, and maybe I need I need to refer the patient to ophthalmologist, so they can do a fundoscopy to see the problem in the patient's eyes, and gastric endoscopy to check the problem in her stomach. One more thing is I need the podiatrist advice if the patient have any ulcer or sore in her foot, so they can check the examination. The treatment for this patient is based on her condition. If the patient has hyperglycemia, so I need to give insulin injection immediately. So, if the patient has hypoglycemia, I'll consider the glucose transfusion. But if the patient can swallow, maybe it's oral glucose, or if the patient can swallow, it will be glucose transfusion through the IV line. And if the patient can swallow and can access the IV, I need the glucagon in intramuscular injection. Also, I need to check the I need to I'll check the vital sign of the patient every 8 hours, and did blood sugar test twice a day. If the patient if the on examination, if the patient has also has a GI problem, I'll consider the medication for the GI problems. The important medication is the medication to treat to control the sugar, the blood sugar level. So in this case, maybe I will consider insulin through subcutaneous injection. So and go through the blood sugar control in the patient's home and prevent complications. I think Tuyen has more experience in these things, and she will present you them.
Compliance with medication and diet is very important to control blood sugar in order to minimize the complication. So I will advise the patient take her medication every day to control blood sugar and blood pressure. Advise she keep a balanced diet. Monitor the amount of protein in her diet. Don't skip her meals because it may lead to low blood sugar. Low blood sugar is very dangerous. Recommend the patient call for help or follow up when she feels fatigue, sweating, hunger, and abnormal heart rhythm, tingling around her mouth. Another one, check her blood sugar every day at home by glucometry before and after meals. In addition, do exercise regularly to improve circulation to her legs. Care of the feet is very important. advise the patient keep her feet lean and moist, wear fitting shoes, and don't walk by barefoot. And the last one, the patient should be followed up regularly to check for hemoglobin A1C and kidney, liver function, her nerve, and eye damage. That's all.
All right, thank you. Dr. Din or Dr. Ho, would you give advice to the group?
Okay, I think that we go back to the same thing that today. Just look at the class, and a lot of people are not here. So I will think about the format again, how to make the people more interact with the studying case. Because the problem with us that you try to explain something and you just copy from the textbook and you don't fit with a specific cases. So that's why people just sleepy all the time. That's a problem. Okay. Something that I will let Dr. Fu and Dr. Brian tell about the contents of the presentation, because I'm not expert. I'm not very good about the knowledge about that. However, I think that I have two things here to ask, to tell you. Number one, just again, glucometer, because a lot of people mispronounce that glucometer is under the second syllable. It's not glucometer. Okay. And Tuấn, why you use EMG for neuropathy? I'm just curious about it.
So, because
okay, speak louder, Tuấn.
So I think the EMG may have me may have me measure the how much problem with the peripheral neuropathy. So because I can measure how weak of the muscles.
And you think when you have the peripheral neuropathy, which area that you're looking for? Okay, that's it. So I just want to tell you, okay, you can tell us everything, yeah? But in the complication of diabetic, just remember the most 4 common places that you need to know. Okay, so that's that one. Okay, thank you.
Yeah. Would you please, Dr. Ho?
Is it the last one, Brian?
Yes.
Last case. Okay.
Yes.
I think it's first of all, it has an improvement. I can see their language skill. Looking on the global camera, I think the class somehow, I think the case been somehow between case too long and somehow a bit lost interest, and some they did not follow the case. You got to learn from people's mistake and improve yourself. It's not an easy. I found still, if I'm not being so difficult, I still found so many. I'm not sure the performance is satisfactory yet, because in medicine you you have to formulate in your mind before you come to talk to the patient. And you must be very sharp, has to be very sharp before you talk to the patient. You have formulate in your brain within seconds that what you formulate need to come out to your mouth. Somehow you're still not sure what you're saying and what your plan are, and you're moving around and try to figure out what you can say next. That's a problem. I think most class still having issue. With diabetic, just to go back to this one, overall, summative my assessment, this talk. Remember, diabetes is very common. It is a modern society. In Vietnam, it's a big, in the next 5-10 years, it will be massive increasing of people with diabetes. A lot of them are under diagnosis at this stage. Or the fast food, or the food intake people taking, like especially like you look in America, Vietnamese people live in America and other Western world. You talk about gestational diabetes in pregnancy, it's 30%. It's astronomical amount. It's high. It's very high. And diabetic leads to massive long-term complication. So you have to be very, very, involved in this case. And it's a chronic disease. You have to formulate and what you do now and what you do for long term. So back to this case, I think I typed some up in chat. With the case, this case is a bit hard for you to say which way you go, to take history, do a physical examination or management. But Dr. Brian has set up all the case here. So the patient presenting with the symptom and the sign there. So that something must be in your brain, there must be that diabetic complicated diabetic. So but you have to come up with first for differential diagnosis. You think what wrong, number of cases thing. Then you try to clues them by your assessment and by your history and by your physical examination, and you come up with a diagnosis. So mostly like in the case of diagnosis, what I would do, this is the patient present with the most likely of diabetic nephropathy, diabetic neuropathy, diabetic retinopathy. But I need to include other causes, could be the central nervous system, blah blah blah. You go on to to check. First of all, this patient, you need to make sure you take check the blood sugar level. That's fine. You check blood sugar level. That's good. The first thing, you correct them. It's an acute man. Could be an acute case. You manage them first, and you go on to do your next assessment. Even though the case told you peripheral nephropathy, you're not sure. You have to test it. You prove it. You not just take it lightly. Easy. You can test sensory, test reflex, and check the power, check the tone. Take only 30 seconds to do the test. You got to tell them. You remember in checking the nerve, sensory, the pain, sensory, light touch, the tone and the power and reflex. That's very quick in your brain. You go, why the foot more affected most? Because that's the longest nerve running down to your leg. It should be affecting the longest one. So then, and secondly, if you're checking your retinopathy, easy. You got to the what's it called? That I forgot. You look in the eye, the back of the eyes, you can see retinal bleeding or retinal vasodilation or vascularization in the back of the eye. You have to learn that. It's so simple. You don't need to dilate the pupil. You can have a look at but ophthalmologist will dilate the pupil to look. And also you check and make sure they got any symptom like operate the nephropathy. These are mostly treat. You remember polyphasia, polydipsia, and polyphasia. So again, just doing fine. If you're very good, I'm happy with the way you're better. You probably learned from the last couple of group before managing the patient and long-term management. Lifestyle change. Lifestyle change. It's not just tell the patient you go home, you eat. It never work. It's not going to work. They just go home, back to the farm, back to the village, everything back to the same. Even in the city people in here, even in Vietnamese community living in Australia, we tell them what to do. You can check in them, but not follow about 20%, no more. You have to reinforce them. How to reinforce them? To get someone to involve. You know, diabetologist, podiatrist, all that. But they don't in Vietnam, they can't afford it. Then you have to get the family involved. You mentioned little disease, you know, long-term the amputation, long-term the blind, long-term the kidney, renal transplant. Emphasize them. This is a long-term problem. You get onto that and management education. But one education time is not enough. Multiple people. Get them, want to get in the head and do it. But get the family member involved, not just a single 80-year-old, 60-year-old, 80 or the other 90. You tell them education and forget it, they're not going to do it. To get someone else to involve in that. And fortunately, in our country, in Western world, we got a whole battery of team to help. Vietnam still very loosely in a way, but the will eventually will change. So I think one thing, this is the diabetic. You go back whole class. Remember, this is just the problem, the chronic problem. It's just one example. You can look later on many other people with renal failure. You can look, the long-term management, short-term management, long-term management. You have learned today acute medicine, acute management. Always that's bang, bang, bang in your mind. ABCD can't go wrong. The next talk I told you obstetric, emergency. If you don't do ABCD, patient will die. It's easy that way. So you got to get sick of mind, and all class please involve, learn from your friend mistake and learn it. But I think it's overall good fun, good to watch this scenario, and good to watch. But still, you still need to build up your system. Somehow the system had to be just easy. If you flick in your brain and you get a system to come out and you talk, and no problem. But good, and I really enjoy it. You listening, and also sorry because I let my daughter do medicine too, so might give you a bit of help. But I think today I'm very I'll try to get my wife. My wife specialized in this field. She's very good in terms of looking, but she doesn't want to be involved. So sorry. Why you ask me diabetic? I know more about diabetic because I was trying to be, wanted to do diabetic, doctor. I didn't get it, and I didn't. And unfortunately, I lied to do surgery, so I want to move to obstetric gynecology. But that's why especially I do IVF, so I have to spend 1 extra year training in endocrine. So we don't know a lot of these things. If you want to ask me more about it, I'll just message me. I can let you know how to manage many endocrine disorders, not just only one. Okay, so thinking diabetic is multiple system disease, just not only one. And you can do many things. ECG, you can do EMG, you can do CT, you can do calcium score, do everything, CT, but many things. But try to simplify. Manage patient as at the simple one first. Bring in too many investigation will lead to a lot of confusion and complication. It's hard to do it. Not easy. Take your time. Thank you. While here, I'm not sure. You assigned me the topic of your obstetric emergency. I'm not sure. As all student has been, study obstetric, because it's a little bit hard for me. They haven't been doing the term obstetric, so might be a big challenge for me there.
And Phu, I think that maybe the whole class will make a feedback to us again. But
okay.
You are 5th year and 6th year student, and I think a 4th year student, they all have a rotation to the obstetric training.
Okay, all right, okay, that's good. I'll stick to it then. Okay.
Okay, and number 2, that in your class, and Phu, we will concentrate the oral report.
Right.
The third part. The first part is an interview, like with the OCA, Socrates, and then this one is that patient interview And then the third part, the last part that you have the class there is an oral report. So that's the way that we do.
Okay, all right, okay.
Okay, now class, I would like to tell you something. I just say one word about the diabetics. Dr. Fu and Dr. Rand talk to you a lot, but I just want to say one word you remember from me. That diabetic patients usually don't have compliance. There's no compliance because these are long run and there's so many things, so they don't follow instruction. Okay, so remember that one. Non-compliance is the most characteristic of people diabetic.
Yeah. Okay, I would like to give feedback on this for this presentation. The first with the differential diagnosis, you give out the differential diagnosis. I have disagree. Okay, because I think patient is more likely coming with hyperglycemic than hypoglycemic. The differential hypoglycemia on this patient is not someone that I'm looking for. She also common with some GI symptoms. We can think of you know, like dyspepsia on this patient. Maybe yes, it can be thrown in. And another differential diagnosis maybe gastroparesis on one of the complications of the patient that slow down on gastroparesis. The other thing is patient can have hypothyroidism as well. So those differential diagnosis that I'm looking for rather than hypoglycemia. You did good about manage of the patient, checking his blood glucose, her blood glucose to see where we are. That's good. Another thing, you got to think this patient, she kind of patient who come into the office, who is stable enough to come into the office. She different than the other patient that come to hospital with very acute issue. So you can slowly treat her and work her up. You don't jump in like, oh, I'm gonna give insulin for this patient. And another thing on this case, you gotta approach the patient with systematically, like Dr. Ho just said. You don't throw in a whole 9 years of work up lab and tests. Okay. The thing is, you need to act and work like doctors. For example, patient come in with hyperglycemia, uncontrolled diabetic, and you work her up for liver enzyme, which is, I don't think it's related and necessary. You work her up with carotid Doppler, which is unrelated as well. Why you need carotid Doppler for? She didn't come with stroke or syncope or anything like that. We don't need those. Okay. And another thing about the EMG, we normally don't do EMG to diagnose peripheral neuropathy on the patient. It's just simply, if you, like Dr. Ho just said, you should use your doctoral skill to examine the patient to figure out those symptoms. Like patient coming with numbness and tingling on her leg, reduced sensation, stuck in like numbness, and you use your monofilament, you test patient sensation vibration, deep tendon reflex, you probably diagnose the peripheral neuropathy without EMS. I'm sorry, EMG. And throw in like CT scan on this patient is not. I mean, another thing is you said patient should be sent to podiatrist and ophthalmologist to see if any wound in the feet. No, you don't. Yes, you do. You do mean you send a patient to the podiatrist every year to check up. But at a doctor, she is present right here in your office. Just use your eyes. check her feet to see any wound, any cut, any swelling, any abnormal. Is this something like a first-year medical student, or like, you know, like her husband at home can do for her? They don't need a doctor degree to do that. Okay, so you have to act like a doctor, a patient in front of you before you send anybody else to any doctor. And before you send her to the ophthalmologist, yes, according to the guideline, we have to send patient to ophthalmologist to dilate the pupil. But you have to do fundoscopy in your office as a primary care physician. You're not doing the best, but you're doing your best, but it's not the best that you can. I mean, you provide your best to the patient. You may not have the medication to dilate her pupil, but you do fundoscopy on patient. Sometimes you can see like cotton wound sign or like her blood vessel engorgement in the retina. So you can see those signs with your before you refer her to anybody else. You can catch so many things by just physical exam. Okay, that's the feedback for the group. Thank you.
Okay, anyway, class, today I think that you improve a lot. Okay, even that we always make mistakes all the time, yeah? And this is a process of learning anyway, okay? But the problem that because we should change something that we have to make you more active, yeah? Because like that is a little bit passive in the way we do. Anyway, for next time, I think that you have the holiday, and after that you back with Dr. Win. I'm not sure yet that Dr. Win will teach you something, but I think that's mostly that maybe go with terminologies and some basic of imaging in English. Okay, this one is not. It's one session. It's not cover everything in imaging at all, especially about medical knowledge. So we just concentrate in how to speak in English. Okay. Then after that, you will see Dr. Mindo for hypertension and shock. And I think that we still do something that like patient interaction. Then back to Dr. Fu again, and we start the last skill, that is a oral report. How you report to your colleague, how you report to the other professional, health professionals about some cases. So that is the most complicated, and you know how to make it short, precise, and in the timely manner. Okay. Okay. Anything else, class? You have any question or something? Okay. Just one. I want to tell you too. Every instructor here, they may have different styles. So if you have any question, just ask them directly. Okay. Sometimes I don't have the answer for you. Okay. So you should ask. Okay. Be active. Okay. To see that what's next, what we have to do something. Okay. For today instructors. Thank you. Dr. Fu?
I'm happy. Just one little sensitive issue. Next week will be holiday. Okay, we happy because the war finished, but please do not celebrate too much, because that day there are million people happy, but a lot also million people was really miserable. Just enjoy your holiday. Don't celebrate too hard. It might hurt our feeling. Okay, enjoy your holiday.
Dr. Fu, do you have any?
Yeah.
Brian.
Do you have any summarize for this class? I mean, any feedback to the whole class for this section?
I think I have to provide the feedback. So far, their English skill improving, in very, in quite a remarkable way. It's, especially they speak Vietnamese every day, not like us who have to speak, English with the patient all the time, and that become sometimes we feel, like, because then we expect them to speak like us, but probably sometimes I forgot, completely. I thought, oh my God, they speak different way from me, but I'm apologize for that. That's the best they can do, and I'm very proud of the way they speak very well. I just one thing, somehow I just still find difficult how to get whole class engagement, because a lot of downtime, and if I was the student sitting at that table, I feel the same. I got probably the same feeling that I'm sitting here, waiting for my turn and 3-hour class, and I have only, about 10 minutes to come to talk, and that's it. And sitting here, sometimes a bit, the instructor, blah, 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 so long, and somehow feel boring. I fall asleep. I think that really significant issue. I try to resolve it. Sometimes I'm not sure how I can do it. It's difficult because online, but somehow students try to help us to see you participating and try ask question, typing question to ask us. So make us feel like you're engaged with us. Make me feel bad that I leave you whole class sitting there and only talk to 2 people. It's a bit somehow I feel a bit for you guys that do sitting there and do nothing. So secondly, I'm still hard to find that. I'm just maybe been difficult, but try to get the system in yourself, system, and try to build up your own system, how to deal with it. Chronic, what in the chronic case, what I would do. In your acute medicine, acute case, what I have to do, just build up that your own one thing there. And if you don't sure, just go down to emergency to practice on the patient. Blah 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 bang, and you will get some some information. Practice your system. What the system get in your brain is just so easy to do, especially your English, your second languages. But I think in general it's good. But probably it's good. I don't think I got no negative feeling about this age. But it's hard for students study, at the same time, study Vietnamese same time and study English on the weekends. A bit difficult. Okay, so class, I'm sorry I'm getting crashed today, but I'll just probably try to help. Okay, so enjoy holiday, guys. I'll just let you know that might be too premature, but I have booked ticket to go to Vietnam, and I've been Cần Thơ. Probably I drop by Saigon for a few days before I fly to Germany, but I might be in Cần Thơ maybe on the 26th of December. I hope to see you guys there. Okay, good.
Thank you, Dr. Fu. Yeah, for my feedback to the class for this section, I feel like I'm happy with your English skill, as Dr. Ho and Dr. Din was saying, and in terms of knowledge, I feel like I'm happy with your presenting as well. at least we learn how to manage the acute cases and the non-acute cases, like the last few cases in the office. Just develop the system in your head, like Dr. Ho just said, to see who is your patient, what they're presenting for, and how acute they are. So you approach your patient. The other thing that I just realized is a lot of students in the class don't know how to manage hypoglycemia patient, hypoglycemic patient. It is a surprise, you know. It sounds very easy. It sounds very simple to recognize sign and symptom of hypoglycemic, but you not really get into the big picture of hypoglycemic patient. Hypoglycemic patient, if you don't treat, they don't have anything to eat, their blood sugar keep dropping, and they're gonna pass out. They're gonna have syncope. They're gonna be lethargic, comatose. So patient, I keep hearing the advice, like when you have a symptom of hypoglycemia, you go to hospital. No, you gotta act right now at home, or either on the bus, or whenever you go. You don't have time to go to hospital. Okay, get something too sweet to eat or drink. Put the candy in your mouth. Drink a cup or 2 cups of juice right away. Eat a meal right now. You don't, and then report it to your doctor later, but you gotta act it right now, because if not, patient gonna get into comatose. The other thing is monitor blood glucose. A lot of students here don't know how to teach patients to monitor blood glucose either. You monitor blood glucose in the morning or before meals, in case of the patient at home and still have like uncontrolled diabetic, then we have to like closely monitor. We monitor blood glucose before meals. Don't ever monitor blood glucose after meals. And that's what I heard, before and after meals. No, if you monitor after meal, it's gonna be 200, 300 after you eat. And what's the point? You teach patient the wrong thing. Okay. And the other thing is, like I just addressed to the last group. If you see the patient with diabetic patient, and they present with like patient is not reliable, non-compliant, please check their feet by yourself. Put the gloves on. I know it's gross sometimes to check the people's feet, but that is your job. That's what you sign up for. So check the patient feet. Don't say, oh, okay, I'll send you to podiatrist. First, we don't have podiatrists in Vietnam. Secondly, you don't do exam on your patient. You don't act like a doctor, and stop ordering like whole naya of tests for the patient. It's gonna be their nightmare, because patient will say, oh, I have diabetic. And then I go to the doctor and they order like, $10 million or 10 million down of workup. It's not working for the patient. Our patients are very poor. And I think that the feedback. So look at how to manage your hypoglycemic patient. Okay. And Dr. Dan, do you have any feedback for the class?
I think it's all for today. Okay, I'm a little bit sleepy now. Okay.
Okay.
Anyway, now before we go, class, you have any more question before we can close the class here? Any? So just somebody in maybe the team leader of team A, team B, or no, not team C is not here. So maybe Dr. Trọng Phú, okay, just say something before we can close the class now. And okay. We need your feedback because there is our part two. Okay. The problem with us that we don't have a lot of active interaction. Yeah? Just so. Okay. Now, Phú, Dr. Phú, yeah. Turn on the mic. Yeah.
Can I say by Vietnamese?
Yes.
Okay. Dạ. Trước hết em xin cảm ơn Dr. Brian, thầy Phú và thầy Vân đã dành thời gian cho tụi em có buổi học hôm nay. Thì em thấy hôm nay mình được một cái ưu điểm đó là kịp giờ. Thì em thấy là có vẻ là mình giảm cái số lượng case lại, mình tập trung về chất lượng thì em thấy nó thoải mái hơn. Nhưng mà cũng tiếc là giống như là sẽ có một số bạn không có được có nhiều cơ hội để mình nói như cái này, thì chắc mình sẽ suy nghĩ thêm để có cái cách nào đó nó toàn vẹn hơn. Em cũng tại vì em thì làm chuyên về bên hồi sức cấp cứu, nên em thấy một số ca về cấp cứu tăng đường huyết hay hạ đường huyết thì em thấy rất là hay, nhưng mà tiếc là mình không có cái cơ hội để mình đào sâu vào những cái kiến thức nó thiên về kiến thức, chẳng hạn như cách xử trí, cách bù dịch hay là cách dùng insulin ở thời điểm nào. Thì em thấy các bạn sinh viên thì hơi thiên về cái khâu mà mình giáo dục mình về sau đó hơn, mà em thấy nếu mình được thì mình nói sâu về cái chọn xử trí thì nó cũng có nhiều cái để mình học. Dạ, ý kiến của em.
Ok.
Mời bác sĩ Vân.
Cho nên cái lớp này em hãy chú ý là cái lớp này một chút xíu nha. Mục đích của lớp này là không có để mình tắt cái chỗ đó cho echo á. Okay. Yeah. Mục đích của lớp này là không có thay thế cho trường y Cần Thơ của mấy em. Không có dạy về kiến thức. Kiến thức là rất tốt, nhưng mà chúng tôi quan trọng nhất là làm sao cho mấy em nói được tiếng Anh, giao tiếp bằng tiếng Anh, sử dụng được những cái danh từ y khoa bằng tiếng Anh, và với cái cách suy nghĩ và đối xử với bệnh nhân, cái đó là quan trọng hơn. Dĩ nhiên là về kiến thức thì các bác sĩ ở đây đều đã làm việc trong các bệnh viện, do đó có nhiều kinh nghiệm về đó, nhưng mà cái đó không phải là cái chủ yếu của mình. Giống như là anh Phú đã nói thì cái anh bác sĩ Phú đã khuyên các em nhiều là phải suy nghĩ theo cái cách systematic. Tất cả cái gì đều phải xem systematic, chứ không phải là chúng tôi không phải là vô chi tiết của từng cái kiến thức một, không có thì giờ đâu, mà cũng không phải là mục tiêu của lớp này. Do đó còn chẳng hạn như vậy thì ý kiến của bác sĩ Trọng Phú rất là hay, nhưng mà tôi nghĩ mình không có thì giờ gì đó. Rồi.
Yeah. I agree with the answer from Dr. Din, because our objective for this class is more like communication, English, communication effectively between providers and patient, doctors and patients. So I didn't emphasize much about the treatment and the doses. You know, for the DKA and HHS treatment the treatment very much straightforward. You know, you just give patient IV fluid, you know, a lot of IV fluid, 200 to 250 milliliter of normal saline, or different fluid. It depends on electrolyte, sodium level, or potassium level as well, and insulin drip, you know, 1 to 2 units per kg, and adjusted according to the finger stick. So it's very straightforward. But again, it's not our main purpose of this class, so that's why I didn't include. I just try to make it more simple. I can throw in more more slides on my PowerPoint to tackle on that part. But yeah, I can do the treatment a little bit more. But you can read anywhere else as well.
Okay.
Yeah. So
Okay.
do you have other questions?
Cho nó rành cho không? Cái mà mấy em cần á là participation và nói. Có thể nói thế nào cũng được, nhưng mà phải nói chứ không phải là thảo luận cái này đúng hay cái kia sai, mà thảo luận là cách nói như thế nào đúng và cách nói như thế nào sai. Cái đó là cái quan trọng nhất mà tới giờ thì tôi nhận xét mấy em có tiến bộ, có tiến độ, nhưng mà vẫn còn nhiều thụ động, không? Do đó thì làm sao mà chúng ta phải tìm cái phim cách nào đó để mà làm sao mà mấy em tham dự nhiều hơn. Từ ngày hôm nay như thế thì là đúng giờ, nhưng mà ít lại không có cơ hội cho những người nói. Do đó như đề nghị của anh Phú hôm trước nhiều khi chúng ta sẽ đưa ra một cái topic và thảo luận trên cái topic đó, mà tôi hy vọng là cái oral report là chúng ta sẽ làm được, và mấy em phải tự động nhào vô nói, hoặc là chúng tôi phải chỉ định nói là bất kỳ randomly pick up, thì như vậy thì mấy em mới không lơ là. Tại vì một số em lên trình bày là mấy em khác là làm chuyện khác, cái đó nó không có trúng với cái lớp học của chúng ta. Xin hết.
Thì thường thì bác sĩ Quang Phú tốt hơn bác sĩ Trọng Phú. Vấn đề vui cái là khi hồi bắt đầu cái lớp mẹ em nói chuyện bệnh nhân nó hơi cảm thấy khó chịu, nhưng mà thấy mới mấy lớp mà thấy nó khác biệt, thấy có vẻ là dịu dàng chút xíu, ít bị đánh hơn. Chắc đó là vấn đề là tôi rất là vui là các em có nhận xét được cái lúc mình nói chuyện, cái nói chuyện nó hơi nó có tình cảm thế này, nó rất là tốt, đúng không? Thì nói chuyện bệnh nhân mình tôn trọng bệnh nhân tôn trọng mình, qua lại thì với cái thứ hai là vẫn còn những cái là mình chú trọng về cái cấp cứu acute medicine too much, mình chú trọng đó, mình quên cái phần sau nữa. Đó là lý do anh Khang nói là tôi cố gắng làm đào tạo cho em nhìn thấy một cái hình ảnh mà giống như một cái người bệnh nhân mình theo dõi họ luôn suốt cả quá trình, chứ không phải là chỉ vô là tôi chụp CT xong là anh đi về mất tiêu thôi. Thì cái này mình có cái này trong tương lai thì y tế Việt Nam sẽ phát triển theo hướng này. Thì đó cũng là một cái hướng gieo một cái mầm cho các em biết là những cách làm sao mình manage patient để có thể long term để nó đi hướng đó rất là tốt. Rồi kỳ tới là oral xong thì chứ cố gắng làm sao để cho cả lớp participate cái đó. Ok, nó good, good. Đấy, nói chuyện bệnh nhân kỳ này là rất là good, rất là hiền, tốt rồi. Không phải là chê trước đây hay nói chuyện dữ, nhưng mà có lẽ tại mình cái communication giữa người Việt, cái nói tiếng Việt, nói tiếng Anh nó hơi, khi mình chuyển qua nó hơi cảm thấy hơi khó chịu chút, nhưng bây giờ là nhẹ lắm rồi, very good rồi, có lẽ làm về làm dâu người ta được rồi đó.
Mấy em có thấy là mấy em là bây giờ mà interview với bệnh nhân là tôi nghĩ là mấy em có tự tin rồi đó. Ít nhiều khi không chẩn đoán ra được ví dụ ha, nhưng mà ít nhất thì cũng đứng trước bệnh nhân cũng biết hỏi cái gì và phải tìm cái gì. Thì nó hơi có cái lag time, tức là những cái gì chúng tôi mà chỉ dẫn phải một khoảng thời gian sau mấy em mới catch được, nhưng mà nó cũng là một cái direction rất là tốt rồi. Thôi, có gì nữa không? Vũ có microphone, có gì nữa không? Còn không, nhưng mà như thế này nha, tôi rất mong là mấy em phải góp ý trên cái nhóm Facebook về instructor, về giảng viên. Ví dụ như là như thế là mấy em có theo kịp hay không, như thế là mấy em có đề nghị gì. Tới giờ nha, trong lớp học đã thụ động rồi, mà trên Facebook cũng thụ động luôn. có lên nói gì là cứ thank you thôi à, chứ không có nói thêm là như thế thì thầy phải như thế này, thầy phải làm như thế nọ. Cái đó là chúng tôi muốn cái đó, tại như thế mới được. Chứ mà lên thank you very much thì chúng tôi không cần cái đó, không cần cái thank you, mà chúng tôi cần cái feedback của các em để mà cho cái lớp mình nó improve hơn. Do đó bây giờ
Vâng nói đúng á, mình tại thầy tụi này là thích là học trò chỉ mình hơn, mình mới cái gì mình từ cái sai của mình mới tìm. Nghe được không? Vâng,
nghe được, nghe.
Cái sai của mình mới chỉnh được. Đừng có sợ thầy gì, tôi không có gì hết trơn á, không có ăn thịt ai hết đó. Không có đì được mấy vụ em mày, cái em mày chửi gì cũng đâu có đì được, đâu làm gì đâu, phải đừng lo rồi sống và trốn mất thì cũng quề tiền. Đừng có sợ, phải không? Đừng có sợ mấy thầy, mấy tụi tôi dạy học trò này giống mấy học coi, tôi qua đây coi, tụi tôi rất là bình dân, không có gì đó, ai mà nay nói chuyện giống anh em nhau thôi à. Đừng có sợ, không có đi được, cũng đi cũng chẳng làm được gì nhau hết á, thì nó đừng sợ, cố gắng đóng góp đi, làm gì tốt hơn. Chứ nhiều khi giữa cái thank you với cảm ơn biết mình cứ tưởng mình ngồi trên mây không biết mẹ vậy đó.
Ok, thôi bữa nay như vậy là đủ rồi ha. Rồi thôi mình chấm dứt ở đây. Thank you Dr. Phú and to Dr. Phú, Dr. Trọng Phú, Dr. Quang Phú and Dr. Brian, and you make the day today. Okay, thank you.
Yeah.
Bye.
Thank you everyone.